Good morning, guys. I think it's high time we start. Thank you for taking time to join in. So today, Dr. Mugutsi, who is a government medical officer who is rotating with us, learning how to scan. She's doing our short course in obstetrics and gynecology. Will be presenting. She has been with us for close to 6 weeks now. So yeah, so she's going to present. So what we will be doing with all the trainees who come to us is that before they end their training with us, they have to present as a way of demonstrating their progress in the field, and also as a way of us to assess uh, any improvements in their clinical reasoning as far as pregnant women, obstetrics, and fetal medicine is concerned. So Dr. Mugudi is one of those doctors who is going to present today. Please listen to it carefully and be prepared to criticize it and to help her improve so that she'll become a better doctor. You never know, maybe in the future she will decide to be a fetal medicine specialist. So let's hope she'll be inspired by her interaction with you today. So yeah, so Dr. Mugudi, over to you. You may start. Thank you.
Thank you, Dr. Veringer. Good morning, everyone, and thank you for joining us. I'll be presenting on two interesting cases that I encountered whilst I was working at Salim Mugabe FMU. So I'll begin. So the first case is of a patient, 26-year-old Primi Prada, Miss FM, presented as a referral from Waterfalls Cancer Clinic to Salim Mugabe Hospital admissions. She was at 25 weeks gestation at the time. She presented with a weak history of bilateral leg swelling and elevated blood pressures. So as a history of presenting complaint, she reported swelling started off involving both feet and progressed to the mid-calf over a week. She also said she had a frontal headache that had started 3 days prior to presentation. However, she denied any blurry vision, epigastric pain, and she hadn't had any fits. She also was not complaining of any lower abdominal pain, backache, and she had no drainage of liquor. She had no PV bleeding. And she did admit that she was perceiving normal fetal movements. Just a background of the pregnancy, it was when she went to Waterfalls Cancer Clinic, she had one ANC visit, which was at 25 weeks, and PMTCT was code 0. The systems review was otherwise unremarkable. She had no other complaints, and on the medical history, she didn't have any prior history of hypertension, and she had no chronic illnesses. Gynae history, Menarche was at the age of 12. She experienced regular menses, usually 4 days. She did not use any contraception, and she had never had any VIAC screening. So we went on to examine her. Her blood pressure is elevated with a systolic blood pressure of 169 and diastolic of 102. In general,
Oops, I think we've lost her, but she will come back into the meeting soon. Let's just be patient with her. She'll rejoin us. Sorry, guys. I think Dr. Admin is trying to help Dr. Mugutsi to get back into the meeting. Please bear with her. I think we should be fine as, just now.
Hello. I'm sorry,
Yeah,
guys.
I
I
think
was
she's
experiencing network
coming back
challenges.
right
I
on.
hope it won't happen again. Can I start?
All right. Yeah,
Okay.
please, you may start. I think there are a few people who joined after I started. You may just restart, Doc.
Okay.
Please go ahead.
Okay. Okay. Can you see my screen? Okay. Good morning, everyone. So I'm presenting a 26-year-old primipara, Mrs. FM. She presented as a referral from Waterfalls Cancer Clinic to Sally Mugabe Hospital admission. She was 25 weeks at the time. She had a weak history of bilateral leg swelling and elevated blood pressures. So she reported that the swelling started off involving both feet and progressed to, it was now involving up to the mid-calf, and this happened over a week. And this was also associated with a frontal headache that had started 3 days prior to presentation to Sally FMU. However, she denied any blurry vision, epigastric pain, and she hadn't had any fits. She also didn't have any lower abdominal pain, no backache. She wasn't draining any liquor, and she wasn't bleeding. She also admitted to perceiving normal fetal movements. So the pregnancy was booked with 1 ANC visit at 25 weeks gestation when she went to Waterfalls Cancer Clinic, and the PMT-CT was code 0. And the systems review was otherwise unremarkable. And in the medical history, she had no prior history of hypertension. She didn't have any chronic illness. Just a brief history on the gynae history. Menarche was at the age of 12, and she had regular menses 4 days, and she did not use any contraception. She never had been screened for cervical cancer with FIAC. So she was examined, and her blood pressure was elevated, 169/102. The range was from one systolic of 154 to 169, and an elevated diastolic as well of range 95 to 102. The pulse was normal, and she was apyrexia. Her weight was 88 with a height of 156. She had bilateral pitting edema up to the shin with a swollen abdomen. The height of fundus was 24 centimeters. The fetal heart was hid, and it was regular, and it was a cephalic presentation. We didn't do a vaginal exam at the time. We then did urinalysis, and she had 3 classes of proteins. So our differential diagnosis at the time was preeclampsia with severe features. Oh, sorry, just trying to go to the next page. Okay. So we went on to do investigations. We did a full blood count, and it was essentially normal with a normal white cell count of 5. Her HB was 12, and her platelet was also normal, 255. The other biochemistry were not out at the time of the presentation preparation. We also then did an ultrasound obstetrics and Doppler, and the findings were as follows. A diagnosis of severe early onset fetal growth restriction was made, and we also noted abnormal Dopplers. The fetal heart rate was 155, and she had estimated fetal weight of 712, percentage of 7.1%. She also had anhydramnios, and we also noted moderate abdominal maternal ascites. The placenta was also of advanced maturity, grade 3, with legs. I took pictures of the ultrasound that we did. So the umbilical artery, which is being shown here, had reversed end diastolic flow with a high PI. I hope it's clear. And then we also did the MCA, which was showing signs of redistribution. It had increased end diastolic flow, and the PI was quite low. It was 1.09. We also this is the ductus venosus that we took. It was showing a reversed A wave and a high PI value of 2.37. The uterine arteries, both of them, the left and the right, were notched with also high PIs. I hope everyone can see. Okay, so the treatment of preeclampsia is delivering the baby. However, our patient was 25 weeks gestation, and the baby was weighing 712 grams. So that was the dilemma. So we sat down with the patient and we counseled and gave her the options that we could deliver the baby after giving corticosteroids. However, this was associated with high chances of postnatal complications and fetal demise, or we could do expectant management, trying to control the blood pressures as much as we can, and then monitor her. So after counseling, she came back after a day. We saw her, she was alone, and then she said she wanted to wait, and if her blood pressure is okay, she wanted to wait and see what happens. So unfortunately, 4 days after we saw the patient from the initial presentation, the baby died. The midwives could no longer hear fetal heart rate, and the ultrasound also confirmed. And then she was induced, and she delivered a vaginal delivery, and the birth weight of the baby was 629 grams. The mother then went home 3 days post-delivery on nifedipine after her BPs had settled back to normal. So this is the end of the first case that I saw. It was very interesting, mainly because of the dilemma that was there, that the pregnancy was 25 weeks, and the fetal weight still very low, 712. That's when you try to balance, should we take the baby out? Will the baby survive? The mother really wanted a baby. This was her first pregnancy. She was very anxious. She was young. Yeah. But at the end, she then decided to wait. But unfortunately, the baby deceased. So my discussion, I then chose to just briefly go through the possible effects that
Sorry, Doc. Sorry, maybe before you go to the discussion, any questions people have on the case in terms of how the case was managed, or whether the care plan was the right one? If you have any concerns, please raise them. Those who can't speak, you can just text or read your question. And yeah, we just want to hear what people think. 629. Do you know what is the survival of babies who are below 1,000 grams at Salem Mugabe, Doc?
Sorry?
What's the going home rate of babies who are born below 1,000 grams at Salem Mugabe?
I wouldn't know of the rate per se, but I do know that the
But take a
survival
guess.
rate is quite low.
Okay, take a guess, a figure.
It's quite low.
I mean, a figure.
I would say less than 50%.
Then you are very generous. It's actually less than 10%. It's less than 10%.
Oh my
So
gosh.
it is 629, unfortunately. It will be even worse. Maybe it's less than 2%. The chance of these babies going home at 629.
Let me see.
Okay. Makwaza is saying what? Below, from what I heard, they rarely survive. Yeah, you are right, Makwaza, that the survival is less than 5% for such babies. But
Mm.
ethically, once a baby weighs 500 grams, you have the right to give the parents the option to say, should we deliver and your baby take the 1% chance? Because some people would want to take a 1% chance because risk takers differ. Some people don't want to take a 1% chance. So modern care requires that parent be told this information and they make an informed choice. So you can go ahead, Dr. Wenge. Please speak, Mary.
I think she can have a look at a study. There's a study, I've forgotten the name, that was done in 2015, 2016 for Harare Hospital and Parenyatwa that actually said by then there was a policy that they would not resuscitate babies less than 1,000 grams. And the babies are actually dying within 6 weeks of delivery. If they weighed less than 1,000 grams was actually 92%. And then even the survival rate for babies less than 8,500 and even 2,000 wasn't good then. I'm not sure whether there's anything that was anything new or any new information or any study that has been done after that one. My only question to her is if you had aimed for conservative management, what would have been your aim? Or when would you say this is now time for delivery? Did you have an end point after offering the patient conservative management? Thank you.
A very good question, Dr. Wengede. Please, Dr. Muguri, do you want to make an attempt? Or the team who were involved in the management can also chip in and tell us what was their end point?
I think at this stage, because the Dopplers were showing reversed signs of redistribution and the fetus was at the verge of compensation, the chance that there would be fetal death was very high. We could have tried to monitor the baby daily, but because of the stage where she presented and with the very abnormal Dopplers, I think in the end, she might not have even reached 1,000. But if maybe she had presented earlier and she still had a normal ductus venosus, we could have monitored maybe every 3 days and aim for maybe a birth weight of 1,000 grams. Also depending on her blood pressures, if they remained stable and she also didn't have any fits.
Was there evidence of fetal compromise in this case?
Yes.
Was there so there was evidence of fetal compromise.
Yes.
The management of early onset fetal growth restriction is always guided by the truffle study. So the truffle study is one of the parameters you guys reported there as an indication for delivering babies before 32 weeks, because like you rightly pointed, we always tell patients that if there is reversed ductus venosus, your baby is likely to die in the next 3 days, which is happened in your case. That the baby died. People know that the baby died on day 4, but I believe the baby died within 3 days from the time you guys saw the baby. So this is the message you always told the parents, that if you see a reverse AF in the ductus venosus, your baby is likely to die in uterus in the next 3 days. Because this is what was observed in this truffle study. So, yeah, so I think for this case, the parents, the option was not expected versus delivery. The option in this case was supposed to be expected delivery versus accompaniment or abandonment in uterus. This was supposed to be the option. To say, would you want to be delivered now, or you feel that you are not willing to go through a process of being sectioned, considering the poor outcome, but you feel that you also don't want any form of termination. You want natural things to happen natural, which is called abandoning in uterus. So I think this was the option, ideal option for this couple to say, would you want us to do something, or you don't want us to do anything? More so if the maternal side is stable, to say, if we don't do nothing, your baby is going to die in the uterus in the next 3 days. Or if we decide to deliver, we can't induce you, because if we induce you, we are terminating, because this baby is not going to come out alive. We are terminating. Say that the woman has chosen termination. Probably let's make them 3 and say there are 3 kind of options to give to this woman, to say we can deliver you by Caesar so that your baby maybe can take the 1% risk and fight for the 1%. Number 2, we can choose to abandon the baby in uterus with that's the patient's choice. Number 3, they could choose termination of pregnancy, whereby the baby could be induced, whether fetal side done or not done, but the outcome, I think, will be the same if they had to be induced with misoprostol. The baby will still demise on its way or immediately, in view of the lack of any form of reserve on this kind of babies who have a reverse ductus venosus. Right. But very interesting case. I think there's a question. Let's hear what others think there. Here in Zimbabwe, not deliver babies below 1 kg or less than 20 days. From what I heard, they rarely survive. You are right, they rarely survive, but there are few who are outliers. This is why we always told the parents that the chances are very low, maybe as low as 2%. But you are going to meet couples in your practice who will tell you that, doc, I want to take the 2% and do Caesar on my baby. Some will come and tell you that mine will survive. I believe in God. So please deliver mine. So there's no prescription here. What is important is to give the patient the full message so that they make an informed decision to say, do you want us to cut, do you want them to cut, or you want them to abandon the uterus? I think we'd have cancelled the family for termination with our local, but inform about international study. Not really, doc. There's no prescription. You give them the options that we discuss here, and they choose for themselves. There's no forced kind of choice. No, they should choose, because we have 500 grams that have made it, and those parents are super proud with their babies. So you cannot say, please terminate. No, you give them an option, then they choose what they want to say. Look, doc, with all the information you've given me, let me continue, or let me abandon my baby in uterus, or please do a Caesar. How do I address maybe the same? Okay, I think we've addressed the question from Carla there. Does the monitoring of doublets change in that case because presence of fetal anomaly, or is just the same? We once witnessed the same case at UBH. What? Let me see, read the whole question. How do you address maybe the same case with abnormal Doppler find the presence of maternal hypertensive disorders of pregnancy, the presence of fetal anomaly like severe ventriculomegaly, right? Your case is different here. In this case, we already have a debilitating pathology, which is severe ventriculomegaly, which is associated with severe mental handicap in more than 50% of the cases. So in this case, probably these parents are wise to be told that even if the baby is to make it, there's going to be severe neurological handicap, so that probably these parents should be given enough information. They are more likely to choose termination if they are given adequate information into all that the pathology underlying. And always remember that severe ventriculomegaly has to be investigated, find the underlying cause. Okay. But very interesting case, doc. The only thing which I wanted to find out, when you guys chose the expectant, you didn't mention how you were going to monitor this baby, because expectant doesn't mean that you are going to forget the patient she goes home. How do you monitor a patient with a reverse ductus venosus who has declined to be delivered?
In this case, would continue admission, monitor blood pressures every 4 hours with a daily urinalysis, just to make sure that the mother remains stable. And then in terms of the fetus, I think daily ultrasound scans would help, and with the Dopplers.
Yeah,
But I'm not sure at which point.
it's daily Dopplers for this kind of a case. Reverse duct, within the ductus venosus, you want to do Dopplers every day. That is the correct way to do it. Yeah, daily Dopplers for with that kind of a case. No need to do daily analysis, by the way. I mean, no need to do, but you may need to do preeclampsia blood probably 2 to 3 times a week to just make sure she's not deteriorating. Maybe twice a week urinalysis rather than daily. Right. So, yeah, good. I think for the sake of time, why don't you go to your second case? So that people discuss your case, then you can always present your discussion before you have time at the end.
Okay,
So that
thank
you
you, Dr.
present your
Werenga.
case. You're welcome.
So the discussion was on the effects of preeclampsia. I divided them into fetal effects and maternal effects.
Sorry, Doc. I was thinking, why don't you go to your second case?
All
Then
right.
once we are done with the second case, we can go to, yeah, we can come back to the discussion. Thank you so much.
Okay. So the second case was interesting. I had never seen triplets or delivered or been involved in a triplet case. So this is why I chose this one. This was Miss TM, 26-year-old para or gravida 2. She had 1 miscarriage in the first trimester. The gestational age was 33 plus 3 at the time of that I saw her. So she presented as a referral from Glenview 1 clinic with a scan report showing a triplet pregnancy. The pregnancy was planned, it was and booked at 18 weeks. She had 4 ANC visits and the PMT-CT was code 0. At the time when she came to Sali FMU, she had no complaints. She was not, she had no chronic illness and her gynae history was generally unremarkable and she had no surgical history. So we went on to examine her. Her blood pressure was normal, 134 on 77, a normal pulse. She had a weight of 56 kgs and a height of 161. There was no edema, no pallor, and her abdomen was of note was that it was a big abdomen with the height of fundus of 39 centimeters, and we noted multiple fetal poles that we palpated and the fetal heart rates were normal. So we then went on to do an ultrasound scan, OBS and Doppler, and then we confirmed that indeed she had 3 babies, triplets, and we determined the chorionicity. It was a triamniotic trichorionic pregnancy. The triplet one was a girl, breech, and she was on the maternal right, and estimated fetal weight at the time was 2.0 kgs. Triplet 2 was on the maternal left, cephalic, it was a male, 1.9 kgs. Triplet 3 was transverse, maternal right, upper segment, a male again, 1.8 grams. There was no significant discrepancy in the estimated fetal weight, and her Dopplers were normal. So this is the ultrasound scan that we did, just trying to determine the chorionicity. I think we saw her at Sali FMU about, we did 4 ultrasound scans. So this is one of the earliest at around 18 weeks, which is showing the lambda sign. And we're also measuring the deepest for of one of the twins. I hope it's visible. So the outcome, unlike the other one, she was a young patient and she went home happy. The patient was admitted and given dexamethasone course. The aim of the delivery was at 33 weeks. So she had 33 weeks plus 5. She was sectioned and she delivered 3 healthy babies. The first baby was 2.1. The second baby was 1.8. And the third baby was also 1.8. They had normal APGAS 8 8 out of 10 at the first minute and 10 out of 10 at the fifth minute. They were, however, admitted for transient tachypnea of the newborn, all of them for about 4 days, and then they were discharged. The discharge weight was, for the first triplet, was now 1,860 grams, and then the second baby from 1.8, he was now 1,720 grams, and the last one from 1.8 was now 1,590 grams, respectively. The mother was very healthy and very happy. So yes, that's the second case that I saw.
Great. And you all have got 2 cases, right?
Yes.
Okay, great. I thought you were going to present the triplet trap. Anyway, it's all good.
Yes, I considered it, but I wanted to see I thought it would be better if someone then presented the outcome
Later with the outcome,
after
right?
the baby's
Excellent.
born. Yeah.
Okay, great. So the case which I'm referring to, we have a triplet pregnancy with 2 normal babies and a trap. In that pregnancy, we are following up at Sally. So it's an interesting case. I think one of the guys who presented, very interesting case, that one. So yeah, I think let's ask some more questions on this case now. Were there any complications, Doc, on this twin? Would you think the twin was complication-free, or you think there were some twin complications?
It was they were normal. Besides the mild respiratory distress that was noted post-delivery, they were okay.
You think they were?
In terms of the ultrasound findings, from the time we saw from 18 weeks and all the scans we did, they remained normal, with normal fetal weight gain and normal Dopplers throughout.
But there's something which is pretty obvious there, isn't it? That number 2 and 3 were small, isn't it?
Yes.
Yeah. So in other
The
words,
2 boys, yes, they were wearing
fetal growth
1.8.
restriction affecting number 2 and 3, right? Yeah, which occurs probably in more than 90% of the triplets. Yeah, more than 90% of the triplets we are going. It's almost close to 100%. I mean, we've not followed triplets where all babies at an appropriate weight up to date of all the triplets that we have looked after. So selective fetal growth restriction is common. It emphasizes what we always say, that humans were never designed to carry multiple pregnancies, where the uterus is not able to feed all the babies well throughout the pregnancy. So yeah, any questions we have on this particular case, or we could reverse some questions that I'm seeing on the first case if we don't have any questions for this case, so that we give Doc the time to just go through a discussion of the 2 cases. So when should triplets be delivered if they are okay?
The books, the literature that I read was saying 33 to 35, but the average is 33 weeks.
It's 33 weeks. Yeah, we have tried to push them to 34 to 35 weeks for those who are complication-free. I think this is what we've done for most of the cases now. But of course, if there are complications, then delivery can be done earlier. The reason why 34 is because studies on neonatal outcomes, perinatal outcomes, have shown that babies born after 34 weeks, their outcome is just as good as those born after 37 weeks. This is why, for us, the 34 weeks is quite a crucial time to try and push any pregnancy up to. So yeah, between 34 to 35 weeks, there are some women who are super strong. As you see more and more patients, you begin to be able to profile different patients here. There are some who actually carry those triplets like they're carrying nothing, who actually go all the way up to 35 weeks and they have to be done seizures without any complaint, and baby's doing well. just some mild FGR only on one or two of the babies. So, but there are some who really struggle with the triplets. So I think delivery timing between 33 to 35 weeks, you have to individualize based on your patient's profile. You have to be able to profile your patient as you see them. That you say, this one, I think she can go all the way to 35. This one, if we take to 33 weeks or 34 weeks, will be grateful. Yeah, so what is the risk of preterm birth? In triplets? What percentage of them will deliver preterm? Because more than 80%, yeah, around that figure there, around more than 80%. So your case represents one of the few cases who go on to, I mean, okay, I should have worded myself when it says spontaneous, because remember, they are more than 80% because of iatrogenic, but spontaneous preterm would deliver at least before 34 weeks. That's the figure I'm looking for, to say those who deliver spontaneously, you plan for them to say, I want to deliver at 34 weeks, but unfortunately, they will go into labor. What percentage is it? It could reach around 50%. That most triplets will end up going to labor before your scheduled time. So just be aware of this. This is where we need to always check the cervix. Whenever they come, and we always need to warn them that they may go into labor. Dr. Pasha was asking to say, would daily CTGs have helped in your first case? What is your comment, Doc?
I think the CTG would have been abnormal as well.
Yeah, so daily CTG monitoring is another way of doing it. Although interpretation of a CTG at 26 weeks is extremely difficult. The only thing maybe you can comment much about is if there are decelerations, because these babies invariably, earlier on in gestation, the variability is reduced, right? So it's an extremely difficult CTG to read at 26 weeks. But what would work in this case is the computerized CTG, which we do not have at the moment. So if we just do a conventional CTG, the interpretation at 26 weeks is always going to be tricky for most people. They may think there's an abnormality and they need to deliver when the baby is actually normal, because they don't have a lot of variability, these babies, at 26 weeks. So yeah. Would you want to go through your discussion briefly? You think you can do that, or?
Okay. Let me start with the preeclampsia one. So I just briefly touched, just to remind us on the possible effects of preeclampsia. So I divided them into fetal effects and then maternal effects. So like our patient, one of the effects is intrauterine growth restriction, and this is mainly due to placental insufficiency. And the other consequence, which we also saw and we gave to our patient the option of delivering the baby, prematurity and its associated consequences. And then, some may actually then demise, especially in our mothers that book late and they're unaware that they actually have high blood pressure. Some even come in with eclampsia and you don't hear any fetal heart. So those are the three most common effects of eclampsia on the baby: UGR, prematurity, delivery, preterm delivery, and intrafetal demise. On the maternal side, the immediate causes was eclampsia. The patient comes in fitting, and then you record a high blood pressure. And the other thing that can happen is HELP syndrome, where you have abnormal liver enzymes and low platelet syndrome, which is a HELP syndrome. And then the other thing, the mother can go into preterm labor. Or they can suffer from a cerebral hemorrhage during delivery. They can also suffer from postpartum hemorrhage especially if they've had HELP syndrome, they will now have bleeding tendencies. So this was my discussion on preeclampsia effects. Should I go on to my discussion about triplets?
Yes, please go on.
Huh?
I think we're not
So
seeing,
my
I
discussion.
don't know if your slides are still sharing because we are not seeing them.
Okay, let me try to see what I can do. Can you see?
Yes, we are good now. You may go on.
Okay. So my discussion was on triplet management. Let's go to. Okay. So in generally, the guidelines say we need to offer triplets in first trimester scan so that we can determine the gestational age, chorionicity, and amnionicity. So the chorionicity and amnionicity are the ones that we then determine the rest of the management, giving an individualistic approach. But unfortunately, most of our patients present in second, sometimes even third trimester, and this makes it very hard to determine the chronicity and the amnionicity. But you have to, when you're doing an ultrasound scan, you have to determine, because then this determines how you're going to manage the patient. And as a general rule, you need to estimate the gestational age from the largest baby, as some of the babies in a triplet pregnancy may be suffering from intrauterine growth restriction, and you might estimate the gestational age, and this has its own consequences. You also need to assign nomenclature, not just say triplet 1, triplet 2, triplet 3, cephalic. It's good to then specify that triplet 1 is on the maternal upper right, to ensure that if someone else then scans, there's continuity of care, and if there are any abnormalities, we're able to pick it early. And then the other guideline was we need to offer women with uncomplicated triamniotic triplet pregnancy at least 9 ANC visits, and at least 2 of these should be with a specialist obstetrician. So it is good now that we have Sally, FMU, and if you're where you're working, there's no obstetrician, you can then refer them, and then they can decide whether to then send them to FMU or not. And then we also need to explain to the mother that they might get into spontaneous labor, as Dr. Verenga mentioned, even before 35 weeks. We also need to measure the cervical length and screen for preterm delivery. So the first time that we need to measure the cervical length is when between 16 and 20 weeks. And then if you notice that the cervix is less than 25 millimeters, 25 millimeters or less, you need to offer progesterone, high dose progesterone, and this helps. And then ideally, the question of when do we deliver, we need to offer C-section between 32 to 34 weeks, unless there is a complication that you have seen during the ANC visits. So this is specifically for triamniotic, trichorionic. As I mentioned before, management or the time of delivery is usually individualistic, depending on how the mother is coping and also how the babies are coping, based on your findings on the ultrasound scan and examination findings. You also need to explain to the mother that sometimes continuing beyond 35 plus 6 weeks has no associated benefit. It actually has an increased risk of fetal demise. of either one or all of the babies. This is the end of my presentation. I don't know if there are any questions.
Yes, do you have any questions for Dr. Mugutsi here? Dr. Mugutsi, the last slide didn't sound very much like fetal medicine there. Yeah, that slide there. What you want every audience here to understand is that triplet pregnancy cannot be looked after without scanning every 4 weeks. The moment they are diagnosed at 12 weeks, if they are the good types, because you always have to classify them, to say, are they trichorionic or there are two groups, the trichorionic and the non-trichorionic, whether they are dichorionic triamniotic or they are monochorionic triamniotic. So there are two groups here, the trichorionic and those who are not trichorionic. The trichorionic are going to be looked after the same way as the dichorionic twins. That is, from 12 weeks, they should come for their next scan at 20 weeks. Then from 20 weeks, they should be seen every 4 weeks. And for each of these visits, they should have an ultrasound scan. They should have their cervix assessed during the scan to screen for triplet complications. I think we've already said that there is going to be selective fetal growth restriction more than 80% of the cases. So there's nothing like uncomplicated triamniotic triplets should have this kind of visit, because you cannot know in advance that they are not going to have selective fetal growth restriction. So this is why their care plan should be cleared from the word go. The woman should be told that you will be coming to see for scans every 4 weeks to check how your babies are growing and compare them amongst each other, and also check the cervix every 4 weeks from 20 weeks. If they are monochorionic, if any of them are monochorionic or dichorionic triamniotic or monochorionic triamniotic, then the game is totally different. We're now in the monochorionic management care pathway, where from 12 weeks, they have to come at 16 weeks. From 16 weeks, they have to come every 2 weeks. To do what? To screen for monochorionic complications such as twin-to-twin transfusion syndrome, TAPS, and also selective fetal growth restriction, because they will invariably have this kind of complication in most cases. So this is why I think the slide here probably just needs panel beating. So that sounds fetal medicine, because the issue is people would think that this is what you should do with the triplets, but triplets should always be categorized into chorionicity. They say trichorionic, we look after them this way. The ones who are not trichorionic, that is either they are dichorionic triamniotic or monochorionic triamniotic, we look after them this way. So that it becomes very clear to anyone who encounters this kind of triplets. But otherwise, I want to applaud you, Dr. Mugutsi, for the sterling work you've done, and for the great acquisition of knowledge you've done during your time with us, because the issues you are discussing here are not simple issues. They are extremely complicated, and even those who are in training actually struggle to comprehend them. So you can imagine the amount of work you had to do to get to this level. So well done, Dr. Mugutsi.
Thank you, Dr. Renga.
Yeah, well done, well done. You've done an amazing work there. I don't see any questions in the chat box. Do we have anything else to tell Dr. Mugutsi concerning what she has done? But she has done an amazing work, really. Amazing work. I think you have also taught us that it is possible. Because I always get concerned to say, should I challenge GMOs to this level when they come, but it proved me wrong that you can do it. So all future trainees will have to present the way you have done here. Thank you so much. Okay, others are asking if we could upload this meeting to the YouTube channel. Yes, it will be uploaded. Then, yeah, I think the rest of the comments, somebody asked if we follow the truffle for, yeah, more or less you follow the truffle for twins. But remember, in twins, you always cancel the issue of abandoning one of the twins in uterus. If one is suffering, the other one is healthy and the gestation is not good. So because we could have one twin who is really suffering and the other one is super happy. So it's always a delicate balance in twins to try and balance the two sides. But we follow more or less the truffle protocol for twins as well. Any more questions from you guys, from everyone in the meeting today? Thank you so much for attending, and your attendance make the meetings great because our doctors here, they know that they have a good audience from you. We hope you found the presentation interesting. Otherwise, we are going to end the meeting, and thank you so much, everyone. The next meeting will be in 2 weeks from now, where probably another presentation will be done. But otherwise, all the best and enjoy the rest of the weekend. Bye-bye.
Thank you, everyone. Thank you, Dr. Verenga.
Welcome. Enjoy the rest of your day, and I hope you choose future medicine. Bye-bye.
Definitely.